So what is tonometry? Well, tonometry is a diagnostic test used to measure the pressure inside the eye. There are many different types of tonometry, including Goldmans, Perkins, and non-contact tonometry. However, the Goldman tonometry process is known as the gold standard, and this is what we're going to be focusing on in this video. And it works by measuring the amount of force required to flatten an area of the cornea by around 3.06 millimeters diameter. So tonometry should be performed under the basis of a few key points, and these include a patient history, so potentially when a patient presents being older than 40 years, a patient ocular history, so whether the patient has hypertension, previous uveitis or diabetes, as well as ocular examination. So looking at the anterior chamber, if there's any pigment in there, any cells in flare, as well as the back of the eye for signs of optic nerve head cupping. Contraindications for Goldman's tonometry may include signs of corneal epithelial defects or membrane dystrophy, if the patient's not giving consent, if there's any signs of infections or abrasions or ulcers in the cornea, as well as the patient being hypersensitive to an anaesthetic. One ocular condition where the technique may be particularly useful might include angle closure, and the etiology of angle closure really looks at the narrowing of that anterior chamber angle and that rapid rise of intraocular pressure as a result of the sudden blockage of the trabecular meshwork. Now, signs and symptoms of this may include blurry vision, painful red eye, obviously a high intraocular pressure, corneal edema, shallow anterior chamber angle, as well as a closed angle and gonioscopy observation. Similarly to angle closure, ocular condition number 2, angle closure glaucoma, has a relatively similar etiology. So eyes with narrow angles as well as decreased iris volume with mydriasis. And you will find that the signs and symptoms are quite similar. So the patient may experience ocular pain, decreased vision, nausea and vomiting, headaches, halos around light, shallow anterior chamber, as well as glaucomatous optic nerve damage and elevated IOP, which may exceed 21 millimeters per mercury. So there will be a video representation shown shortly on the process. However, I will give a brief overview on how it's performed. So firstly, you're going to be ensuring the prism's been disinfected and cleaned and ready to be used. You're then going to check the graduation markers on the measuring prisms aligned with the white marker point on the tonometer head. You're going to check the calibrated dial of the tonometer is actually set to 10 millimeters per mercury, and then you're going to be checking the patient sitting comfortably at the slit lamp. So they're at the right height, their chin's on the chin rest, and their head's resting against the forehead band. You're then going to set the magnification on the slit lamp to ×10 magnification, and then instill local anaesthetic drops with some fluorescein. So you would like to select a blue filter that's going to produce a blue beam, and make sure that beam of light is as wide and as bright as possible. This makes visualizing the fluorescein rings much easier. You ask the patient to look straight ahead and open both eyes nice and wide, and fix his or her gaze and keep perfectly still. So with your thumb, gently hold up the patient's top eyelid, taking care not to put any pressure on the eye, and make sure the tonometer head is perpendicular to the eye. Move the tonometer forward slowly until the prism rests gently on the surface of the center of the patient's cornea. With the other hand, turn the calibrated dial on the tonometer clockwise until the fluorescein semicircles in the prism head are seen to meet the form a horizontal S shape. Note the reading on the dial and record it in the notes. Withdraw the prism from the corneal surface and wipe its tip. So, applanation tonometry measurements are directly affected by the central corneal thickness. A thicker corneal thickness may give an artificially higher IOP measurement, whereas a thinner corneal thickness may give an artificially lower reading. Other limitations may include an excess amount of fluorescein, as well as an irregular or scarred cornea, and also high astigmatism. Now here's a demonstration of the technique.
Hi Lewis, good to see you again. How are those new glasses going?
Hello Rebecca, sorry I didn't book an appointment today, but I just had to come in because I've been experiencing these really bad headaches, and also my vision seems to fluctuate, and I'm not sure if these new glasses or something more serious.
That's okay, we'll see how we can help you today. Tell me a little bit more about this pain though. Where does it feel like it's located?
So this might sound weird, but it kind of feels like the headache's coming from somewhere behind my eye. And yeah, sometimes when I'm driving at night I see these halos on the car headlights. I don't know, it's very unusual, and I just came in to see what the problem was.
I'm really glad you came in today, Lewis. Just to make sure that it's nothing serious, I just want to have a look at the pressure inside your eye. To do that, I'll need to be putting some dye into your eye and having a look at the front surface, and then I'll be using this piece of equipment to measure the pressure inside your eye.
This is strange. I don't think I've had this done before.
Well, it's pretty simple, Lewis. Similar to the blood pressure within your body that we can measure, we can also measure the pressure within your eye. It's similar to a car tire, actually.
A car tire? What?
Well, for instance, in a car tire, if the pressure is not quite right, then the car won't run properly, right? Well, the same can work with your eye. If the pressure is too high or too low, then that might be what's affecting your vision.
Ah, that makes a little more sense. I'm sorry to be asking so many questions, but is this procedure painful? And will it take long? Because I actually got to pick up my kids from school.
No, not at all, Lewis. So we'll be putting some drops into your eye that should numb them, so you won't feel a thing. It might tingle a little bit at first, but you shouldn't feel irritated at all after 5 seconds. The test itself won't take very long either. You just need to check the pressures and then discuss your results with you, and we'll be all done.
Sounds good.
Great, so before we get started, I just need to ask, are you allergic to any dyes or eye drops that you know of?
No, not that I know of.
That's okay, so before we get started, I just need to give my hands a quick wash.
So here we see Rebecca, our practitioner, giving the slit lamp clean, making sure the instrument is ready to be used. Here we see the practitioner setting up the slit lamp for precorneal checks with a blue filter. Expiry dates are checked. So the fluorescein is about to be instilled into the patient's right eye. He's asked to look in towards his nose and up. So now the patient's getting comfortable on the slit lamp set up by the practitioner and is asked to fixate over towards her right ear. The precorneal staining results are recorded, and the patient is now ready for the anaesthetic drop to be instilled into the right eye. The probe of the tonometer is cleaned with an alcohol wipe and left to dry. So the tonometer is moved slowly until the prism rests gently on the centre of the patient's cornea. And with the other hand, you're going to turn the calibrated dial on the tonometer clockwise until the two fluorescein semicircles make a horizontal S-shaped pattern. Now here's a representation of what you might expect to see. At this point in time, the two Myers or two semicircles are meeting each other directly in the centre, which is where you take an accurate recording. However, when the Myers aren't at the right level, so here you show the pressure is too low, as you increase the dial it goes too fast, the semicircles aren't meeting in the centre. After completion of Goldmans tonometry, you will record what pressure you found on the recording sheet, as well as what agent you used and the time at which you completed this technique. You will now perform the post-corneal checks just to ensure there's no damage to the cornea, and you will record this on the recording sheet similarly to the way the precorneal checks were recorded.
So what we found today, Lewis, is that the pressure within one of your eyes is slightly above normal. Now, it's nothing to worry about because pressure tends to vary throughout the day. So what we will do is we'll try and book you in for an appointment tomorrow morning if you're free, and we can check the pressures again then.
This might be a little bit of a silly question, but does it have to be in the morning?
There's no such thing as a silly question, Lewis. In fact, I get asked this all the time. The reason why we want to measure pressure in the morning is because it's a lot higher than it is in the afternoon. So if that pressure within the morning is still a lot higher, then we can follow it up with further testing and have a look at your pressures.
Ah, that makes sense. tomorrow morning actually sounds perfect. Perhaps I could call in after I drop the kids off at school.
Definitely. Before we finish up, Lewis, did you have any other questions that you had for me?
No, I think all of my not so silly questions have been answered.
Well, thanks for coming in, Lewis. I'll see you tomorrow morning. Have a great afternoon.
You too. See you then.